you would like, one needs to consider the overload aspect as well. And in fact, when you think about iron, you might think of the curve this way, that iron has a more narrow range in which adequate dose is at lowest risk, and that in fact when you get into overload or deficiency, the stakes go up more rapidly. Stated another way, if some is good, more is not necessarily better. Okay, so let's move now into iron deficiency during the fetal period and the neonatal human brain. So what kinds of things, we usually think about iron deficiency as being dietary, not getting enough dietary iron, maybe coupled with intestinal blood loss. That is the classic model we think about based on the Lozoff studies and iron deficiency research around the world. I think it's only been more recently that we've started to ask the question, what about the fetus and the newborn? And indeed, that's a very important time period. So when we think about how could the newborn brain be iron deficient, we can think about decreased supply. So the mother is iron deficient and the fetus may or may not be affected by that. We can think about decreased transfer. That's also decreased supply. That's a mother who is iron sufficient, but for some reason the iron is not getting across. And we can think about fetuses that have a much higher iron need than the mother can supply to them. So this slide shows you the decreased supply side. And by far the most common problem, if you look around the world, is decreased maternal iron supply because you have a very iron deficient mother. And various people have looked at how iron deficient does a mother have to be to affect the fetus. And the answer is that under a hemoglobin of 10.5, the mother's ferritin level decreases, and that decreases the iron level or the ferritin level in the fetus proportionately. That doesn't mean anything in terms of the brain necessarily. Once a mother has a hemoglobin less than 8.5, the fetus actually becomes iron deficient. This is fairly common in developing countries. It's estimated around the world that 30 to 50% of mothers are iron deficient around the world. However, nobody has ever looked at the brains of these babies. In other words, autopsy studies have not been done to know what degree of iron deficiency or what areas of the brain have been affected. So when we model this in the rodents, we really don't have an idea of how iron deficient we should be making these models. Now, another way we can get to a fetus who has iron deficiency is either through intrauterine growth restriction, usually due to maternal hypertension during pregnancy. 50% of IUGR babies will have abnormally low ferritin concentrations, below the 5th percentile. Okay? So when you think about an IUGR baby, you're looking at a malnourished baby, but what you're seeing, of course, is protein energy malnutrition, small. But you need to think that micronutrients are also being affected by that lack of placental transport, and iron is one of those micronutrients. In the U.S., that's about 75,000 babies per year. Now here we do have autopsy information. Back in the mid-90s, we did autopsy studies on IUGR babies who died on the first day of life, and we found a 33% or 32% average decrease in total brain iron. That is a large decrease. I was actually very surprised at how iron deficient those brains were. But it gave us an idea of how to model it, and when we get to the rodent part of the talk, I'll show you what it meant. The other possibility about decreased placental iron transfer during gestation would be prematurity. Now here, you typically accrete iron during the last trimester, and I'll show you the figures on the next slide. If you are delivered early, then you don't have the benefit, this is just like calcium, you don't have the benefit of accreting the iron that the term baby would normally have. On the demand side, this may surprise you, But infants born to mothers with diabetes mellitus during pregnancy also have iron deficiency. It might surprise you because when you look at an infant of a diabetic mother, they don't look very malnourished, do they? They're usually very large babies. Again, you're looking at protein energy status. Doesn't mean that there's not a micronutrient problem. In fact, the infant of the diabetic mother, who is often very polycythemic, has such a high demand for iron for the red blood cells that the brain actually gives up iron or doesn't accrete iron in order to provide enough iron to the red blood cells. And it's a very complicated pathophysiology that it took us about 10 years to work out between me and one of Dr. Ziegler's partners, Dr. Widnes. But what we determined over time was that in unselected, that if you just look sequentially at diabetic mothers that come into clinic and deliver, up to 65% of those babies will have low ferritin levels at birth. And that is about 150,000 infants per year. Surprisingly, their degree of iron deficiency is even greater in the brain than the growth retarded baby who is obviously malnourished. And so the principle here, and the one that I would like you to remember, is that iron is prioritized to the red blood cells over the brain. Now those of us who study the brain, we're very disappointed to find out that the lowly red blood cell gets iron in preference to the brain. But I guess you need red blood cells to deliver oxygen to the brain anyway. So any time that iron demand exceeds iron supply, it's going to go to the red cells before it goes to the brain. So think about that when we talk about anemia of prematurity. And this is what I was talking about on the previous slide. Fetuses have 75 milligrams of elemental iron per kilogram of body weight throughout the third trimester. So a term infant has about 250 milligrams of elemental iron, and a 24-weeker has about 37.5 milligrams. How do we know that? We know that from the same studies that Dr. Ziegler quoted to you from Elsie Widdowson and your own study. So this is quite, you can see how much accretion of iron there is during that last trimester. The majority of that iron is in red blood cells. Babies actually have a pretty decent size of storage iron in the liver, and the rest of it is in brain, heart, and skeletal muscle. But remember that the symptoms of iron deficiency, and especially the brain symptoms, come from this very small compartment here, not, we think, from the anemia itself. Okay, so that is how a fetus could be iron deficient, or how you could have a baby who is iron deficient on day one. Now let's talk about premature infants in the intensive care unit. So first of all, premature babies, as I told you before, are born with lower iron stores. And this is an analysis of cord ferritin levels gleaned from a literature search of 25 years worth of literature, 35 articles, plus our own data set, plus the data set from the University of Iowa, to generate curves. And you can see there's a lot of scatter in the ferritin levels, but in general, ferritin levels increase with gestational age, this is gestational age on the lower axis, or stated another way, decrease the more premature you are. And we were able from this to generate normative values that you can use in your unit. The average term baby has an average ferritin level of 134, the premature baby 115. The 5th percentile is about the same for both. So a profoundly iron deficient or low iron store baby is going to have a ferritin less than 40, let's say. And that's a number I want you to keep in mind, because we've used that number to look at memory abilities in newborn babies as a function of their iron status. Okay. Now, what happens once they're born? They're born with lower stores. What happens during hospitalization? Well, I probably should have one of those figures of Libra with the two pans, and you have the scales of justice. Here we would have negative iron balance on one side, positive iron balance on the other side. And these are factors that contribute. So what contributes to negative iron balance? First of all, low endowment. So if you have a preterm baby who is intrauterine growth restricted as well, they're going to be starting with lower amounts of iron. If you drain them of blood for your laboratory studies, they will become more iron deficient. If you delay starting iron therapy until 2 months of age, they will become more iron deficient. If you treat them with less than 2 milligrams per kilogram per day of iron, they will become more iron deficient. If you stimulate erythropoiesis with EPO and don't supply them with adequate amount of iron, you will drain the stores and the brain probably. And if you have a rapid postnatal growth, and I think this is something that people forget, a rapidly growing baby is more likely to become iron deficient. Why? Because they are expanding their blood volume to match the growth, and they're making red cells. Again, iron is prioritized into the red cells. So rapid growth has been associated in many different studies with negative iron balance. And of course, the flip side is, if you're older in gestation, if you receive red cell transfusions, if you are treated with iron starting at 2 weeks instead of 2 months, if you treat with up to 4 milligrams per kilo and 6 milligrams per kilo if you are on EPO, if you give parenteral iron, which we don't typically, and if you have a slower growth rate, and that will tip your iron balance more to the positive. The question I want you to think about, and I don't think is resolved yet, is there a component of anemia of prematurity that is due to iron deficiency? Again, Dr. Ziegler's partner, Dr. Widnes, has spent most of his research career trying to figure out the various components of anemia of prematurity. Is it erythropoietin secretion? Is it resistance to erythropoietin? Well, among the studies that he and I have done together and others have done, there appears to be an effect of iron deficiency as well. And one of the pieces of evidence for that is that preterm infants with hemoglobins that you wouldn't even blink at, a hemoglobin of 10.4 in a 34-week baby. I don't think any of us would transfuse or think of as being iron deficient. In fact, those babies have elevated zinc protoporphyrins, a measurement of not having enough iron to incorporate into the hemoglobin. Again, if iron is prioritized to the red blood cells before the brain, then does a baby who is showing us that the red cells are struggling also perhaps have brain iron deficiency? And that's not known. Okay, what about after discharge? This is a study that is not published yet. It has been reported at PAS, at our SPR meetings, the last 2 years, updates, and we finally finished enrolling all of the kids in this study. There's 162 kids in this study now. But some early data from it showed that when we looked at premature babies at 2 months of corrected age, that many of them had low hemoglobins. This is about a quarter to a third of the babies had low hemoglobins, and that even those with a normal hemoglobin, many of them, about 15 or 20%, were struggling to maintain that normal hemoglobin, meaning their serum transferrin receptor was elevated and they still had very low ferritin levels. And that suggests, and these babies were being fed an average of 3.3 milligrams per kilo per day of iron. Okay? So remember that the recommendation in the NICU is 2 to 4 milligrams per kilo per day, and the discharge formulas provide about 2.25 milligrams per kilo per day. So in fact, in this study, we were actually 1 milligram per kilo more in our dosing, and yet we are still having quite a few babies trying to maintain their red cell health. And again, if the red cell health is compromised, what might be happening to the brain? Okay, so we keep invoking the brain. Let's look at what the effects are of early iron deficiency on the developing brain. There are over 40 studies now, most of them from Betsy Lozoff's lab, but there are over 40 studies that demonstrate that